Bismillahirrahmanirrahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on complete agenesis of the right hemi-diaphragm in an adult. You can watch this lecture and other lectures by visiting my YouTube channel using the URL at the bottom of the slide. We start by describing the embryonic formation of the diaphragm. Embryonic formation of the diaphragm takes place during the 3rd to 8th weeks of intrauterine life through the participation of 4 major structures, namely septum, transversum, pleuro-peritoneal membrane, dorsal mesentery of the esophagus, and the innermost thoracic wall. So this picture demonstrates the embryonic formation of the diaphragm. On the left side, we see the 4 components of the growing diaphragm, the septum, transversum, which will form the central tendon later on, the pleuro-peritoneal membrane, which will form the muscular part of the diaphragm, and the body wall mesenchyme will form the peripheral muscular part, and the dorsal mesentery of the esophagus, which will form the diaphragmatic crura. Agenesis of the hemi-diaphragm refers to the complete absence of the hemi-diaphragm on one or both sides. Such congenital anomaly is thought to result from failure of the pleuro-peritoneal membrane to close the pleuro-peritoneal canal, or failure of the development of all 4 precursor components of the developing diaphragm. Bilateral agenesis of the diaphragm is very rare, and infants with this defect rarely survive to have surgical intervention. Unilateral agenesis of the hemi-diaphragm is mostly left-sided, while the right-sided cases are extremely rare. Incidence of agenesis of hemi-diaphragm in adults. Most patients with congenital agenesis of the hemi-diaphragm present very early in life, and only few patients have been reported to reach adulthood. Since Bingham first recognized agenesis of the hemi-diaphragm as a distinct entity in 1959, and until 2016, 9 adults with this anomaly have been described. The oldest reported adult patient presenting with true agenesis of the hemi-diaphragm in the English literature was a 66-year-old lady. Herein, we present a case of complete right-sided agenesis of the hemi-diaphragm in a 54-year-old man diagnosed upon surgical exploration 16 years earlier. So we start by describing the case. A 54-year-old male military officer was seen several times after an old right thoracotomy because of chronic shortness of breath, wheezy chest, and post-thoracotomy neuralgia. The physical examination revealed a scar of posterolateral thoracotomy, diffuse rhonchi, and decreased intensity of breath sounds on auscultating the right chest. The patient was a known asthmatic for many years and was operated upon 16 years earlier for suspected huge congenital right-sided diaphragmatic hernia. He never smoked, but was one of the victims of a chemical weapon attack on his village in 1988. The presenting preoperative symptom was progressive shortness of breath of several years' duration. Examination of the chest prior to surgery revealed a diminished intensity of breath sounds over the right chest. Plain chest radiograph, PA, and lateral views showed a great apparent elevation of the right hemidiaphragm. CT scan of the chest showed the herniation of the liver, of the entire liver, into the right thoracic cavity. Entire herniation of the liver into the right thoracic cavity. Likewise, right thoracotomy confirmed the presence of the whole liver in the right pleural space. To our surprise, the right hemidiaphragm was completely missing, which favored the diagnosis of diaphragmatic agenesis rather than diaphragmatic hernia per se. The liver was pushed down, and a big polypropylene mesh size 30 centimeter by 30 centimeter was used to replace the diaphragm by suturing it into the ribs. So that was an operative photograph at the time of thoracotomy showing complete herniation of the liver into the right chest with missing diaphragm. Outcome of repair. The patient experienced only a modest clinical improvement following surgery. However, the follow-up chest radiograph and chest CT scan revealed persistently high liver position. Despite his illness, the patient is still serving in the army, while his chest pain and dyspnea are being conservatively managed. So these are the post-repair chest X-ray and CT scan of the chest showing a persistently elevated right hemidiaphragm and a high position of the liver in the thoracic cavity despite the repair. Discussion. The diaphragm is the most important muscle in the body after the heart. Moreover, it is the most important respiratory muscle. Ordinarily, the diaphragm separates the thorax from the abdomen and prevents the herniation of abdominal viscera into the chest. For reasons not completely understood, the diaphragm may be subjected to congenital malformation, such as congenital diaphragmatic hernias, and rarely congenital unilateral or bilateral agenesis. The latter, diaphragmatic agenesis, is a major anomaly that occurs alone or in combination with congenital defects in one or more body organs, such as the lungs, limbs, heart, gastrointestinal tract, and central nervous system. Literally speaking, agenesis of the diaphragm refers to the absence of this vital musculo-aponeurotic structure. The consequences of diaphragmatic agenesis include stillbirths, early neonatal deaths, and rarely survival to adulthood. The rare bilateral agenesis is so severe that neonates seldom survive to get surgical repair, while few patients with unilateral variants have survived to adulthood and have been reported so far. Diaphragmatic agenesis represents the rarest and most extreme type of congenital diaphragmatic hernias. Some authors refer to huge diaphragmatic hernias with little diaphragmatic muscle at the time of surgical exploration as partial agenesis of the diaphragm. We disagree with this notion and believe that whenever the rim of the diaphragm is visible, a rim of diaphragm is visible as surgical exploration, the case should be considered diaphragmatic hernia rather than agenesis. Travaline and Cordova reported 3 cases of presumed agenesis of the hemi-diaphragm. However, Sheehan et al. Believe that these cases were actually large congenital diaphragmatic hernias, as mesh repair was performed using remnant of the diaphragm in 2 of them. The incidence of congenital diaphragmatic agenesis is 1 in 250,000 births. In contrast, the frequency of congenital diaphragmatic hernia is 1 in 2,200 to 2,450 births. The incidence of adults with congenital diaphragmatic agenesis is likely to increase in the future due to the higher survival rates of neonates who receive better care. In our case, the hemidiaphragmatic agenesis was on the right side, showing rare site of occurrence of a very rare lesion. Diaphragmatic agenesis occurs on the left side in 88 to 97% of the cases, while right-sided defects are less common due to the earlier closure of the right pleuro-peritoneal canal. Moreover, even if right-sided diaphragmatic defects are present, the liver prevents herniation through such defects. Diagnostic workup made in early infancy generally reveals associated genetic malformations, particularly aneuploidy syndromes. Diagnosis of congenital diaphragmatic agenesis in adults is based on a high index of clinical suspicion supported by imaging studies. In adults with congenital diaphragmatic agenesis presenting with cardiopulmonary or digestive symptoms, the main task should be systematic examination of the gastrointestinal tract to rule out pathological lesions in the herniated intrathoracic viscera. The index case, our case, was a 38-year-old military officer, reasonably active despite his progressive shortness of breath. He was initially suspected to have a huge congenital diaphragmatic hernia, according to his symptoms as well as the radiological findings. However, complete absence of diaphragmatic muscle and surgical exploration favored the diagnosis of diaphragmatic agenesis. Since we had no alternative, we elected to repair the lesion by a mesh, despite the previously reported high complication rate associated with this type of repair. The drawbacks of a synthetic mesh repair include recurrence of the defect, patch dislodgement or infection, progressive chest wall deformities, and restrictive pulmonary function. On the other hand, some consider an elective repair of agenesis of hemi-diaphragm by a prosthetic mesh an optimum option. Adult patients with right-sided agenesis are in need of surgical intervention to prevent the herniation of the liver and other abdominal organs. Surgery is also indicated in symptomatic patients with dyspnea or organ herniation to prevent worsening of lung function or visceral damage. Surgical repair of the lesion is very difficult due to the complete absence of the diaphragmatic tissue needed to achieve the repair. Several authors used different therapeutic choices, such as prosthesis, abdominal wall and chest wall muscle flaps, suturing the chest margins with the liver, use of pre-renal fascia, while some recommended no repair at all. The review of the literature revealed sporadic case reports of left and very occasionally right diaphragmatic agenesis in adult patients who were symptomatic or free from symptoms and underwent surgical repair by different techniques or otherwise were managed conservatively. The following slides will show examples. Azire et al. Presented a case of a 27-year-old lady who was referred 2 days after a cesarean section with suspected pulmonary embolism. CT scan of the chest showed herniation of the liver and intestine into the right hemithorax. Exploratory right thoracotomy revealed right diaphragmatic agenesis. The herniated viscera were reduced into the abdomen, and the defect was closed using a mesh. The patient had a smooth post-operative recovery and left the hospital 10 days later. Another case, Ali et al. Described the case of a woman who presented with progressive shortness of breath during the last trimester of her gestation with total agenesis of the right hemi-diaphragm. Polypropylene mesh was used to fashion a new diaphragm, which was followed by good lung expansion and improvement of the patient's symptoms. Sheehan et al. Described a 66-year-old lady who presented with obstruction of the large bowel and discovered to have a complete absence of the left hemi-diaphragm and intrathoracic transverse colon and splenic flexure during exploratory laparotomy, a transverse colectomy with end-to-end anastomosis was done. Mesh repair was considered unsuitable because of the risk of infection. The patient left the hospital on day 60 and was found well 1 year after surgery, although her left hemi-diaphragm was not substituted. Sesi-Tashvili et al. Described a 63-year-old man who presented with a small bowel interruption because of strangulated intestinal obstruction and peritonitis. During exploratory laparotomy, partial right-sided agenesis of the diaphragm was found. Owing to the poor overall status of the patient, repair of the diaphragm with a synthetic mesh was deferred for the future. It is of interest to note that in one article, the authors described successful laparoscopic cholecystectomy in a 36-year-old lady with a previously undiagnosed complete right-sided diaphragmatic agenesis. Samuel and Porath reported the first successful primary repair of a complete congenital diaphragmatic agenesis in a neonate using flaps of latissimus dorsi and serratus anterior muscles, reinforced by a flexible composite mesh. The authors believe that their technique provides the patients with an intact, compliant, functional muscular structure. We wonder if the results of this repair technique of congenital diaphragmatic agenesis in neonates are similarly applicable to adult patients. In our case, mesh repair was done, but the improvement in respiratory performance was just modest. This could be partly attributed to bronchial asthma and previous exposure to chemical weapons. On the other hand, the right position, the high position of the mesh could be another contributing factor. Though mesh repair didn't achieve optimum result, we think it was effective in preventing further herniation of abdominal viscera into the right chest and potential complications. So the take-home messages of our lecture: complete agenesis of hemi-diaphragm in adults is very rare and exceedingly so on the right side. Though clinical and radiographic diagnosis may be straightforward, differentiation from the more common large congenital diaphragmatic hernia may be made only at the time of surgery. To avoid potential complications of right-sided lesions, operative treatment is advised, although the best method of repair is still controversial. Well, this presentation is based on a recent article. I have published this article in the Journal of Faculty of Medicine, Baghdad in 2021. And these are the references of the article. And with this nice photograph of Baghdad, Iraq, I would like to conclude my lecture. Thank you for watching the lecture. This is Professor Abdulsalam Yasin Taha signing off from the College of Medicine, University of Sulaimani.